Hi there, welcome to Explain This, a podcast where we try to explain complex things in simpler ways for people of all ages. I'm your host Jin Kim, and today we'll be carrying on from last week's topic and go deep into yet another thing that we don't fully know how it works, general anesthesia. But before you get scared and never want an operation ever, don't worry, turns out we actually know quite a lot about how to safely put someone under. Let's get started. For a long time in human history, surgeries had to be done with no sedation or pain relief. That's right, if you thought having surgery in the modern day is not fun, imagine having an arm cut off with only a wooden block to bite down on, or being awake while the doctor digs around your insides, or drilling a hole through your skull. Thankfully, we now have the technology to put you under a general anesthetic, so you don't feel the pain of being cut open, and so you won't be aware or have any memory of it ever happening. But the funny thing is, we don't actually know how general anesthesia works to keep a person sedated. Then again, we're pretty good at knowing how to use it effectively, like knowing which specific anesthetic drug to give, how much of it to give for a specific effect, and what to look out for when things go wrong. So let's start by explaining to you what is involved in general anesthesia, as if you're a child. Let's say you've ended up in hospital because your tummy is really sore, and the doctors tell you that it's all because of your appendix being angry, and they need to cut it out of you. Gross. Why do we even have an appendix anyway? It's not like the Lord of the Rings or Dune, where the appendix actually explains a lot of the backstory and deep lore of the world. Anyway, I digress, because that's the topic for another day. Anyway, a doctor cutting into your tummy to cut out a part of you sounds really sore, like more sore than what you've experiencing from your appendicitis. But worry not, little Timmy, for thanks to modern medicine, we can perform all kinds of surgery on you while you're in a dreamless, painless, memoryless sleep. Well, it's not sleep per se. We're not going to sneak into your bed in the middle of the night and stab you. That would surely wake you up. No, we're going to perform something called anesthesia, which is a heck of a word to spell or pronounce. Anesthesia literally means to not feel in Greek, because when you're under anesthesia, your brain isn't aware of what's happening around or to you. The anaesthetist, the doctor who specializes in using anesthesia to put people off to sleep, actually needs to do 3 important things to make sure the surgery goes well. First, as we said, is putting you to sleep, so that you are not aware of what's going on. Because it would be pretty hard if you were awake while you could hear the surgeon snacking away in your insides, even if you weren't feeling the pain. This is called hypnosis, but it's not like waving a yo-yo in front of you and saying, "You are feeling very sleepy," but the medically induced kind that makes your brain much less active. Technically speaking, anesthesia is not the same as sleep, but doctors still use this term because going, actually in front of patients who are very scared of having surgery is not very professional. Anyway, turns out, a lot of the medications we use to put people off to sleep doesn't actually help with the pain of being cut open. Some of them do, but most of the common ones that keep you asleep during surgery don't have any pain relief properties. Which means the second important part of anesthesia is exactly that, analgesia, or treating pain. The anaesthetist will do this by regularly giving you a very strong pain relief, such as morphine or fentanyl, especially when the surgeons are about to do something extra nasty. Because turns out, even when you're sleeping and unaware, your body can still feel pain and respond, such as tensing the muscles or making your heart rate and breathing rate go up. But the last important part of anesthesia has nothing to do with the brain. It's paralyzing the body. This sounds very scary, but it's actually very important because otherwise, your body might move involuntarily off the table, or move when the surgeons are about to perform a very delicate cut. But the problem with paralyzing all of your muscles is, well, you need muscles to breathe. Which means for most operations, the anaesthetist will also have to put a breathing tube down your windpipe after you've gone off to sleep, so they can breathe for you with a machine called a ventilator. There's a lot more to anesthesia, such as keeping your blood pressure under tight control, giving you specific medications such as electrolytes, the thing that plants crave, and fluids and antibiotics, and maintaining the right balance between keeping you asleep enough to be comfortable, while not making you so asleep that you'll never wake up. All in all, as complex as it sounds, we have highly trained doctors who will be looking after your paralyzed, numb, unaware meatbag of a body while the surgeons are cutting you up, so you've got nothing to worry about. Welcome back. So, yeah, anesthesia is pretty awesome, letting us not feel anything or remember anything from even the most major of surgeries. But we haven't always been so lucky. Before we learn more about anesthesia and how it may or may not work, let's take a bit of a history lesson. As we mentioned before, proper anesthesia is actually quite a recent invention. In the ye olde days, people didn't really have an option to be put to sleep for a surgery. Heck, they didn't even have good pain relief. If you look back on ancient history texts, it's very clear that surgery of various types have been around for thousands of years. Even ancient doctors knew the importance of cutting things out where they didn't belong, or stitching things together if they were damaged or loose, etc. They also knew it was bloody unpleasant having to feel all of that, whatchamacallit, noxious stimuli. So there's always been attempts at inducing some level of numbing, or anaesthesia. This involved all kinds of different herbal remedies and compounds such as the classic swig of whiskey, opium from the poppy plant, cannabis, and even various poisons such as mandrake roots. But it sounds like no one in the before Common Era days reliably had a concoction figured out, so for the most part, people just had to grit and bear the pains of surgery. There's ample records that suggest that some people chose death over the pain of surgery. There's a record that a famous Chinese physician by the name of Hua Tuo devised an anesthetic concoction called ma fei san in the 2nd century, and used this effectively to put people to sleep before operating on them, so that they would not feel or remember a thing. This story is important because the first doctor to be formally documented as using an anesthetic to fully render a person unconscious and insensate for a surgery was a Japanese doctor named Hanaoka Seishu, who in 1804 used a concoction of herbs called suzensan, and he made this concoction by studying what Hua Tuo's ma fei san might have been made out of. In the Western world, however, there's no good evidence that anyone figured out the secret sauce for a very long time, like we're talking the 1700s. By this time, the Renaissance had already happened and doctors were much better at understanding how the human body worked, both anatomically and physiologically, mostly thanks to dissections and the scientific method. Furthermore, germ theory was discovered, the theory that infections were transmitted by teeny tiny bacteria and viruses that could be killed using antiseptics and hot water and soap. So doctors started actually washing their hands before cutting someone open, especially if they'd just been cutting open a dead body. That's right, that was the norm before germ theory. This meant that surgery was a more viable and safe choice of treatment for many ailments, which made the topic of anesthesia even more important. By the late 1700s, scientists were discovering that there were certain gases that had some interesting properties on the human body, such as nitrous oxide. When people breathed in this gas, they felt giddy and lightheaded, a whole lot less anxious, and they noticed that bumping into things didn't hurt as much, probably why they called it laughing gas. After about 40 years of research and experimentation, and general shenanigans at so-called nitrous parties where rich people got high off them, some doctors finally got the hang of using this nitrous oxide to give people some pain relief and mild anesthesia during surgery. We still use nitrous for things like dentistry, labor, and joint reductions. But it doesn't fully put you under, so it's not the best option when it comes to major surgeries. Fortunately, the march of progress didn't stop there, and better anesthetic gases were discovered and refined. The two most famous are diethyl ether, sometimes just called ether, and chloroform. You've probably heard of chloroform from movies, where people pour it on a rag, smother someone with it, then drag away the limp sleeping body all sneaky-like. But chloroform can actually be quite dangerous, such as causing cardiac arrest, so please don't do what they do in the movies. First of all, it's legal. Second of all, you'll probably kill the person. Anyway, thanks to careful use of ether and chloroform by licensed doctors, surgeons were suddenly able to perform much more complex painful surgeries, as the patient would be unaware and unable to feel the pain of being cut. It also meant that surgeries could be done much safer, because surgeons no longer had to do it as fast as possible. There's a hilarious yet very macabre story of the famous surgeon Dr. Robert Liston, who holds the world record for the highest mortality from a single surgery. 300%. How, might you ask? How can you even have a higher than 100% chance of dying from a surgery? Well, remember that before anesthesia, you wanted to perform the surgery as quick as possible, because the patient would have to endure the pain. Plus, the longer the surgery went on, the higher the risk of dying from bleeding and infection back then. So, Liston had a reputation for being one of the fastest surgeons of his time, which made him technically a good surgeon. At the same time, in his most famous case, he performed the surgery so hastily, amputating a leg in just under 2.5 minutes, that he accidentally also amputated a few fingers off his young assistant. The assistant ended up dying of a wound infection many days later. The patient also died of gangrene, and there happened to be a spectator of the surgery whose coattail was slashed by the scalpel, and he also died from fright. So, there you go. The only surgery where 3 people died from one surgeon. The story may be apocryphal, but it shows the state of surgery and medicine back then. Anyway, the invention of general anesthesia, the full sedation of a patient during a surgery, revolutionized the field, and surgeons were able to improve their techniques and perform more and more miraculous treatments, all the while keeping the patient comfortable and blissfully unaware. The 1900s brought far more advancements, including better and safer inhalational anesthetic agents, such as sevoflurane and isoflurane, injectable anesthetic agents, such as propofol and ketamine, muscle relaxants derived from the poison curare, rapid-acting potent pain relief such as fentanyl, and techniques to put a breathing tube down the trachea to protect the airway and help us breathe for the patient when they're paralyzed. We'll cover all of these modern anesthetic drugs and techniques in more detail later, but that's about it for the history of anesthesia. It really makes you grateful that we live in an era where if you come down with appendicitis, you can have a keyhole surgery, feel nothing and remember nothing from the surgery, and be discharged the next day with a super low risk of complications or dying from an infection. It was only 200 years ago that we couldn't put you to sleep for painful procedures. Thank you, modern medicine. Alright, so we're back in the modern day now. Let's talk about what a general anesthetic involves and how each part of it works, or how we think it works. By the way, so you're not confused, we keep using the term general anesthesia, or GA, because that describes the act of fully sedating a patient, so they're not aware or feeling things. This contrasts with local anesthesia, when we make only a part of the body numb, such as when the dentist puts a nerve block in your mouth, or we inject some anesthetic agent into a wound so it doesn't hurt while we're stitching it up. For the rest of the episode, I'll use anesthesia instead of saying general anesthesia every time for simplicity. When it comes to anesthesia, turns out that it's not just a one-drug system. There's many different drugs involved, all doing different things. We commonly talk about the 3 main pillars of anesthesia. The first and most important is hypnosis, or putting someone to sleep. Technically, anesthesia is not the same as sleep. It's a very different brain process. The brain is much less active during anesthesia compared to sleep, and most people describe it as if their brain was put on pause when they go under anesthesia, then resumes play when they wake up in the recovery room. But for simplicity's sake, we'll keep using the layperson's term, going off to sleep. To put people to sleep, we use what is called an induction agent. These are powerful drugs that reduce brain activity by depressing the neurons, rendering a person unconscious. Common examples of induction agents include propofol, the drug Michael Jackson accidentally overdosed on, ketamine, also known as horse tranquilizer or Special K, benzodiazepines such as midazolam, and barbiturates such as thiopental. You don't have to remember these drug names, unless you're a budding emergency medicine physician or anesthetist. Now, there are 2 key issues with many of these agents. The first is that they can be very short-acting, so they'll put you off to sleep, but after about 5 to 15 minutes, you'll start waking up again. So we need some other kind of maintenance anesthetic to keep you under while surgery continues. We typically use either a steady trickle of propofol, or we mix in an anesthetic gas such as sevoflurane into the oxygen that we make you breathe during surgery. The second issue is that, with the exception of ketamine, most of the other drugs such as propofol have no pain relief properties. This means that we can put you off to sleep so you won't remember or be awake during the surgery, but your body will still feel all the pain of tissue being damaged as it's being cut. Even when you're unconscious, your body responds to this pain by tensing the muscles, producing adrenaline to raise your heart rate and blood pressure, and producing stress hormones. So, to be nice, we ensure that we respect the second pillar of anesthesia, which is analgesia, or pain relief. Because, obviously, you don't want people feeling the pain of being cut open and yanked and having stuff shoved inside them. Sorry, I'm really not selling surgery to you, am I? We've talked about pain relief in depth in episode 27, so we won't cover it here today. But for reference, this category includes drugs like morphine and fentanyl, as well as local anesthetics and nerve blocks to reduce the pain of surgery even after the patient is awake. The last pillar of anesthesia is not related to your brain, but your body. This is paralysis, because we don't want you moving during surgery, especially if we're cutting very delicate, teeny tiny things such as blood vessels in your brain or your heart. To do this, we give you a powerful muscle relaxant that means your brain can't communicate with your muscles. This includes medications such as suxamethonium or rocuronium. The problem with these medications is that it does nothing to your brain. So if you were to forget the other two pillars and only give muscle relaxant to a patient before surgery, then the patient would still be completely aware and able to feel everything as the surgery went on. Fortunately, this kind of horror story is exceedingly rare because there are so many safety checks to prevent it from happening. Outside of these three things, there are many other things that happen as part of anesthesia. Essentially, the anaesthetist is the medical doctor who looks after your physiology, that is, the function of the body, while the surgeon is fixing your anatomy, the structure of your body. This means that if your blood pressure drops because there's too much bleeding during surgery, the anaesthetist will transfuse you with blood or give you medications such as fluids or vasopressors to increase your blood pressure. It also means they look after your breathing, because muscle relaxants will paralyze your diaphragm as well, meaning you can't breathe for yourself. So, after you go to sleep and you're paralyzed, we perform an intubation, where we slip a breathing tube through the vocal cords into the trachea or windpipe and connect you to a mechanical ventilator that breathes in your stead. There's a few other things that happen, such as monitoring your vital signs, episode 41, get across it, monitoring your electrolytes, and other important things in your blood, making sure you're not having a heart attack during surgery, etc., etc. Now that we have the bases covered, let's get into the meat of the topic. How do these two groups of drugs, induction agents that switch off the brain and muscle relaxants that switch off the body, work? But before that, let's take a very short break. Welcome back. So here's a frightening fact for you. We don't actually know how induction agents work. That is, we know an astonishing amount of how to use it. We know exactly what ratio of anesthetic gas to oxygen gives what effect in a typical person. We know how much medicine to inject into your veins to produce a desirable effect based on your weight. We know what kind of side effects they can cause and how to reverse them. In fact, the definition of anesthesia is a reversible, controlled use of medications to induce loss of consciousness. But we don't know the exact mechanism of how these drugs physically shut down your brain processes to make you unaware of your surroundings. Kind of like gravity in our last episode. We can calculate the exact mass required to launch a rocket to escape Earth's gravity and put it into orbit, or send people to the moon, but we don't know what physically causes gravity or how space-time is warped by mass. The mechanism of how anesthesia works is very hard to study, because, like sleep, it works on the brain. And as we found out, the brain is something we still don't quite fully understand. Like, we know a reasonable amount about how it works and doesn't work, but there's still a lot to discover about how consciousness happens. So, if we don't know how consciousness works, how can we know what causes unconsciousness? Well, funnily, we know more about what makes us unconscious than how consciousness works. For example, there's a very specific part of your brainstem called the RAS, or the reticular activating system. This is the arousal center of your brain. No, not getting you aroused in a horny way, but aroused as in keeping you awake. Turns out, if you mess with the RAS, such as damaging it by trauma or stroke, you render someone unconscious. This is the scalpel method of switching off consciousness. The hammer method is if you disrupt all of the neurons in your brain, say because you don't have enough oxygen or blood sugar being delivered, or you're having a seizure and all the signals are scrambled, then that also makes you unconscious. So anesthesia probably disrupts brain cells either just in the RAS or the entire brain to make you unconscious. But how does it do that? Most drugs work by what's called receptors. Think of receptors as light switches on a cell. Except to turn them on, you need a specific key. Your body produces lots and lots of different keys for lots of different receptors, such as hormones and neurotransmitters, and it controls how much of each of it releases to precisely control which lights are turned on in the cell at a given time, instructing the cells to do more or less of a certain thing. Well, it turns out we can hijack the system by either copying the key, say by distilling the specific chemical such as adrenaline and injecting it into a person's bloodstream, or by using a very similar looking key. This is how most medications and poisons, because medications are essentially carefully dosed poisons, work. They bind to different receptors and either switch them on or switch them off. This can trick the cells to change how they function, letting us lower your blood pressure, slow the rate that you break down serotonin, turn off inflammation signals, etc. This is what we call the ligand theory of how medications work, and we have a really good understanding of it. But with anesthetic agents, we just haven't found any receptors that these chemicals seem to bind to. So how are they functioning then? Well, luckily, we have some theories. For a long time, until the early 1900s, anesthesia was mostly given in gas form, like with ether and chloroform. In fact, we still tend to use gas induction, that is, putting the patient to sleep with anesthetic gas instead of an injection, for children, because then you save them from the horror of being jabbed by a needle while they're awake. Whereas, who cares about adults having needle phobia? Anyway, some clever scientists discovered in 1899 that there was a very important trend between an anesthetic agent's potency and how soluble it is in fat. Potency is a property of a drug that tells you how much of the drug you need to give to produce a certain effect. So, for example, paracetamol has a potency of 1 gram, or 2 500 milligram tablets, to produce pain relief in an average-sized adult. Or, a potent fart is one that is powerful even in small amounts. So these scientists found that if an anesthetic was really lipid-soluble, that is, it would dissolve into olive oil very quickly, it would also be very potent, as in you needed less of it to produce the same depth of unconsciousness in a person. Without getting into the science of the Meyer-Overton correlation and how it was used to deduce the minimum alveolar concentration of anesthetic drugs, yes, you can delete all of that from your mind straight away, please. What all of this means is that there's probably something related between anesthetic agents and fat. So how can we tie these two things together? Neuron disruption and fat solubility. Well, funnily enough, we have plenty of fat in our cells. Sorry, not in, but around. Your cell membrane, that is the bubble that makes up the outer wall of your cells and keeps everything inside, is made up of a special type of fat called a phospholipid. It's special because it has two ends, the fatty end that doesn't like water because it's oily, and the phosphate end that does like water and wants to dissolve in it. Because of this structure where one side wants to go towards water and the other side that wants to leave water, if you put a bunch of these phospholipids in together, the fatty sides all want to huddle together to avoid water, while the phosphate ends face outwards because they're fine with seeing water and they just want to swim in it. This creates a really nice thin membrane called the lipid bilayer, because you get a neat double layer of phospholipids. I'll include a picture in the show note. You don't need to know too much about how cell membranes work, but just remember the fat part. So scientists wondered, what if these fat-soluble anesthetic agents are somehow sneaking into the cell membrane of brain cells, squeezing themselves in between the lipid bilayer, and getting all snug with the fatty ends? This would be like a person carrying a giant cake moving through a crowd. The large anesthetic molecule would push the phospholipids outward to make space, which would essentially cause blebs in the cell membrane. Maybe this blebbing is enough to disrupt the neuron function to switch off consciousness. The theory is that the more soluble an anesthetic agent is, the greater the expansion of the lipid bilayer is, causing a greater anesthetic effect, meaning more potency. There's still a lot of active research going on to try and cover the mysteries of how anesthetics work, but so far the lipid bilayer expansion hypothesis is the leading theory. Now, I said this applies mostly to the anesthetic gases, but since 1899, we have had some amazing injectable agents developed, such as propofol, also known as the milk of anesthesia because it's in a white emulsion, barbiturates, and ketamine. These drugs do seem to work on receptors, like most drugs, but interestingly, there's more than one way to skin a cat. Propofol and barbiturates bind to a very important receptor called GABA-A. GABA, or gamma-aminobutyric acid, is the main downer receptor in your nervous system. When it's activated, it lets in a flood of chloride ions into the neurons, which hyperpolarizes it and makes it less active. We covered all of this in episode 44 when we talked about electrolytes. So when propofol binds to GABA A, it inhibits neuron function, as in it reduces it, probably including the ones in the rat, causing unconsciousness. Ta-da! This is how alcohol and benzodiazepines sedate people as well. At least, we think so. We think that's how propofol works, but it hasn't conclusively been proven yet. It's possible that GABA isn't the only answer, and there's actually a whole bunch of receptors involved in the anesthesia. The really weird one out of all of these mixes is ketamine. Ketamine binds to a different receptor called NMDA, as does nitrous oxide, the OG general anesthetic. NMDA is the opposite of GABA. It's an excitatory receptor, or an upper. When it's switched on, calcium ions flood into the cell, depolarizes it, and turns the neuron on, increasing neuron activity. Well, wouldn't this make you more conscious if that's possible? Well, where propofol bound to GABA to turn it on as an agonist, or agonist, ketamine binds to NMDA to turn it off as an antagonist. Yeah, like in stories. This means that ketamine makes neurons less active as well. But weirdly, instead of just depressing the brain and slowing it down, ketamine produces a very unique type of anesthesia, dissociation. If the other anesthetic agents can be thought of as lowering the volume of a television so that it's quieter, ketamine works by scrambling the brain, causing a dissociative state. It's like static white noise washing out all the sounds so you can't hear anything, like shh. You can see it too. If you give ketamine to a patient at a high enough dose, usually to sedate them for a procedure or to put them under a general anesthetic, you notice that the person doesn't quite look unconscious, but more like they're frozen in a trance. Their eyes are wide open, staring at a fixed spot, like they're having a flashback. It's quite bizarre. It's quite fun because we use ketamine a lot to sedate children when we do procedures. Anyway, that's a lot about how anesthetic drugs work, or how we think they work. And I can't stress enough that even though we don't know exactly how they work, we do know exactly how to use them. It's a weird concept to grasp that you don't need to fully understand something to utilize it well, but those are the kind of difficult concepts we're here to teach. Alright, your brain is probably feeling pretty full with all of these new pharmacological concepts. Let's focus on the body instead now, and talk about how we can paralyze you with drugs. Deep in the Amazon rainforest, hunters have been using arrows dipped in a special poison for centuries. This poison would cause its victim to be immediately paralyzed, meaning even one shot in a non-fatal location would lead you to drop to the ground, helpless and unable to escape. When European explorers came across this technology, they found that the poison was called curare, derived from the extract of various plants. When it was brought back to Europe, doctors immediately realized how useful this powerful poison could be. At first, curare was used to relieve the painful, deadly muscle spasms of tetanus infections and strychnine poisoning. Then in the 1930s, when anaesthetists had mastered the use of induction agents and started dabbling in airway management skills, they realized that they could use curare to paralyze the patients, making it a lot easier for surgeons to operate while their patients were knocked out. Muscle paralysis is very important in surgery for lots of reasons. First and most obviously, you don't want patients moving during a surgery, because there are many sharp things involved. There are a lot of delicate procedures happening, and you don't want the patient falling off the surgical bed. Even if you're unconscious, you can still involuntarily move your head and limbs, particularly if there's a painful stimulus. Kind of like how you might accidentally slap your partner while rolling in bed in your sleep. But also, pain causes muscles to tense, making certain surgical procedures such as abdominal or orthopedic surgeries more difficult. Paralyzing the patient loosens all of these muscles completely, so it makes the surgery much easier. Lastly, remember that breathing is also done by muscles, specifically your rib muscles and your diaphragm. In some critical situations, we might want to take over a patient's breathing for them with a mechanical ventilator, either because their breathing muscles are getting exhausted from overworking, or they're breathing erratically and not getting enough oxygen in or carbon dioxide out. To do this, we need to intubate them, which is a procedure where we put a plastic tube through the mouth or nose, through the throat, through the vocal cords, and into the trachea. But your vocal cords are also teeny tiny muscles, so if you don't paralyze the patient before intubating them, you might not be able to get anything through them. Finally, even if you don't intend to intubate and ventilate a patient, You kind of are forced to if you paralyze them, since they can no longer breathe for themselves. It's a bit of a chicken and egg situation. Anyway, lots of good reasons we'd want to paralyze people. And thank goodness we have such useful poisons such as curare. But how does it work? Nowadays, we don't use curare, but we use medications that are very similar in function, such as suxamethonium, rocuronium, and pancuronium. You can tell from the last two drugs that curare is still credited as the OG paralytic, as seen in the suffix curonium. Muscle relaxants work by preventing the signals from your brain to move the muscles from reaching the muscles themselves. When you want to move a finger, your brain makes the decision in the motor cortex, sends an electrical signal down your spinal cord, down to peripheral nerves of your arm, until the signal reaches the tiny neuron that actually connects to the muscle that controls your finger. This meeting point between neuron and muscle is called the motor endplate, or neuromuscular junction. It behaves very similar to synapses between neurons, which you now know all about. The neuron releases a neurotransmitter called acetylcholine, which floats on until it binds to a receptor on the muscle cell. This opens a sodium channel, letting sodium ions flood into the muscle cell, depolarizing it and activating it. So, with our new knowledge of pharmacology and ligand theory, we now know how we can use medications to stop this from happening. All you need is a medication that can bind to the acetylcholine receptor and turn it off. Turns out, we have two ways we can do this. There's curare and the curare-derived medications such as rocuronium, which bind to the acetylcholine receptor while not turning it on. This is what we call a competitive antagonist. The drug is competing with the natural acetylcholine, preventing it from doing its job. You know, like when there's a rude car parked in your staff parking space so you can't get to work on time. Since acetylcholine can't do its job, the nerve signal never reaches the muscle, and voila, paralysis is achieved. You can thank Mother Nature for giving plants this scary, scary power. And this is why whenever someone doesn't want to take medications because they're unnatural, I make the argument that, well, actually a lot of natural things really want to kill you, and many medications are just these natural things but in much tinier doses. Anyway, I digress. There's one other clever way we can paralyze the muscles, and this one is going to make you go, huh? Instead of preventing the acetylcholine receptor from being turned on, we turn it on so hard that it's dialed all the way to 11. This is how suxamethonium, also called a depolarizing muscle relaxant, works. It's literally two acetylcholine molecules stuck together, and it works by binding to the same receptor, but like really well. It binds for a much longer time than normal acetylcholine, and even better, the enzyme that normally breaks down acetylcholine to stop it from overstimulating the muscle can't break it down. So, suxamethonium essentially does just that. It overstimulates the muscle cell and over-depolarizes it. Which doesn't make sense, right? Surely that's the opposite of paralysis. Well, the cool thing is, if you do this, the muscle cell is so depolarized that it doesn't reset by repolarizing. So even if acetylcholine comes to activate the muscle cell soon after, it won't react. And voila, you're paralyzed. It seems counterintuitive, but it works super well. The way it looks from the outside is that you give suxamethonium to the patient after putting them under, you suddenly see this wave of muscle twitching from toe to face as all of the muscles start seizing up, until all of the muscles all suddenly go limp. Because all the muscle cells are being turned on, but turned on for so long that they go numb for a while, not letting the normal acetylcholine and nerve signals do their job. This is why sometimes after general anesthesia, people complain of muscle pain, because all of their muscles temporarily twitched like mad. This type of paralysis is much shorter lasting than the first type, which we call non-depolarizing muscle relaxants, because they don't depolarize the muscle. But also, it works a lot quicker, so we use the two different types of muscle relaxants for different purposes. For example, you might give suxamethonium to quickly paralyze the patient because they're unstable, put in a breathing tube, then you give them the longer-acting rocuronium to keep the patient paralyzed. I've always thought that it's so cool that we can solve a problem through two completely opposite ways. And to think that a lot of these things are based on nature's own designs. Like, suxamethonium is just taking advantage of the body's normal nerve muscle function and dialing it up to 11, while curare is a natural poison that interferes with this process. Anyway, I think we talked enough about anesthesia, don't you think? let's wrap it up. So, what did we learn today? We learned that for thousands of years, humankind has not had a good way to keep people asleep or even comfortable during painful surgeries. We learned that in the last 200 years, we've discovered many different gases and chemicals that can let doctors make a patient unconscious, unaware, in a reliable, controlled, and reversible manner called general anesthesia. We learned about the three pillars of anesthesia: induction, paralysis, and analgesia. We learned about how induction agents work. Ish. We learned that we think that they work by disrupting the cell membranes of neurons by getting all up in the lipid bilayer. But we also learned about the ligand theory and how some anesthetic agents bind to receptors and either make nerves go sleepy by or scramble their signals to prevent consciousness. We learned about how muscle relaxants work by blocking nerve signals from getting to the muscle through two very different, clever ways. Lastly, we learned that anesthesia is complicated and mysterious. But thanks to well-trained doctors, you can rest assured when you need to have surgery because you'll be well looked after, not feeling anything or being aware of anything during the surgery. Alright, for today's 2-minute explain, let's talk about why some doctors don't go by the title of doctors. Specifically, we're talking about surgeons living in certain Commonwealth countries such as the United Kingdom, New Zealand, and Australia. Even though they go through the same medical school and same rigorous training process as physicians or non-cutting doctors to become specialists, surgeons in these countries use the title Mr. instead of Doctor. But why? Why would you go through 6 years medical school, 2 to 3 years of being a junior doctor, 6 to 12 years of training as a surgical registrar, then maybe a couple years of being a fellow honing your skills, to not go by the special title Doctor? There's a fascinating historical reason for this. As medicine developed, doctors delved further into academic research and the study of how the human body works and how different therapies would treat people. As part of this movement, surgeries were considered beneath the regular doctor, because it was all messy and gory and untidy and appeared barbaric. And fair enough, now that you know about the lack of anesthesia and analgesia, it kind of makes sense. There was probably also an element of surgeries being so dangerous and resulting in so many deaths that many doctors would have preferred to seek non-surgical treatment options where possible. Anyway, we typically use the term physician when we speak of non-surgical doctors, because they deal more with the physiology or functions of the human body rather than the anatomy. Instead, the people who took up the role of surgery, which was still much needed because wars were aplenty and many people needed amputations or lumps cut out and such, fell to another profession that was well versed in the delicate use of the blade: barbers. Barber surgeons were a well-established profession in Europe since the Middle Ages, and they did the bulk of the much-needed surgeries for centuries, while physicians turned further and further away from surgery. That is, of course, until the 1800s, when surgery became a much safer, viable treatment method thanks to the advent of hand washing, antibiotics, better surgical techniques, and anesthesia. Now, physicians had to recognize that surgery had a role in medicine. So they kindly came down from their ivory towers and said to the surgeons, "Oh, so sorry that we treated you like barbarians. How about you join us so we can all be one big happy doctor family?" To which the surgeon said, "You know what? We're going to make our own guild with blackjack and our own titles." I mean, kind of. Surgeons already formally had guilds since the 1700s and had essentially operated as their own profession separate from the doctors. But all the same, the surgeons wanted to make a point that they weren't doctors, they were surgeons. So instead of being assimilated as doctors, they decided to keep the title Mr. to distinguish themselves. Over time, surgeons and physicians joined hands, and medical schools ended up teaching both kinds of medicine to future budding doctors. This is why in countries like New Zealand, a medical degree is a MBCHB, or a Bachelor of Medicine and Surgery. Even so, the traditions live on, and surgeons who have completed their rigorous training and are specialist surgeons opt to go by Mr. instead of Doctor. Funnily, you can't call yourself Mr. until you've finished your full training, so even experienced surgeons who are finishing their training will have to go by Doctor. How sad. Lastly, we're way over 2 minutes, but we need to address this very important point. What about women surgeons? What title do they go by? Naturally, thanks to the frickin' patriarchy, women weren't allowed to be neither doctors nor surgeons until very recently. So the traditions sadly don't even bother respecting them. So there's no definite answer on which title women who have finished their surgical training go by. They might use Miss, Ms, or Mrs., They might ignore the tradition and use doctor. And there are certain examples where people have said, you know what? I've done all this hard work and I'm damn well going to take the title that I've earned, and use Mr. Well, that's it for today. Thank you for listening to Explain This. Hope you learned something interesting and maybe even useful today. We'll see you next time. Bye for now. Explain This was written and hosted by me, Jin Kim. If you'd like to suggest a topic or just send a lovely message, you can email me at explainthiscast@gmail.com or follow me on Facebook or Twitter